Okay, talk from here?
It's better to talk over there.
Okay. It's good. It takes me further away from you guys. So the reason I come is not only does Mel send me patients, but he's the reason I'm in Queens altogether.
See so. Put it close to your mouth.
Okay. He's the reason I'm in Queens. I was working at Einstein and at Jacobi for a long time and left for a variety of reasons and went into private practice in the Bronx. And Mel came to me one day, because I knew him from Jacobi for a long time, and he said, "I need help in Queens, would you come?" And that's how I came to Queens, so I owe him for that. And the second thing to say is this is Old Home Week. Kew Garden Hills, my aunt used to live here, and so we spent a good bit of time here. And I remember playing touch football with two guys she didn't like. She was a teacher, and these guys were always fooling around with their guitars and stuff. Simon and Garfunkel from here. So it brings back interesting memories. I'm going to talk about very complicated stuff. Let me say a few things first. I mean, Beth sort of blasé about oncotyping, but understand these are studies of active genes, what genes are turned on in a breast cancer. We couldn't have done anything like that a few years ago. And the same thing applies to a lot of the other things that we do. One of the things Beth didn't mention in terms of genes, and it's important for an Ashkenazi Jewish group, is the BRCA1 and BRCA2 genes. We're the chosen people. We have iliac disease and all kinds of stuff, that Crohn's disease and Tay-Sachs, and the list goes on. One of the things we have is a very increased incidence of breast cancer because of a gene that we can detect and study. Turns out that that gene is also positive and abnormal in other diseases aside from breast cancer, so it's under more use. But the nice thing about it is I can have a patient, I can put something in the patient's mouth, they get it wet, and I send it to Myriad Genetics, and back comes the gene analysis of these patients. I mean, unheard of a few years ago. I've been an oncologist since 1974, a little while. And in the last 5 years, the progress has been astounding. I'm just going to touch on two parts of the progress that we've made in the last 5 years. Two big topics, and I'm going to skim through it because to get into detail is going to drive everybody crazy. The first one of these is the use of antibodies, of specific material to attack a cancer by some kind of an antibody mechanism. The first one we're going to talk about, and actually overlaps with Beth's story a little bit, is monoclonal antibody therapy. What the hell does that mean? It turns out that cancer cells often have, not as often as you would like, but often have a protein on the surface that is different from what other cells in the body contain. And you can target them. You can make an antibody to that antigen, as we call it, this surface protein. And if it has very low toxicity, the first one that we developed was something called rituximab, which targets something called CD20. It's an invaluable agent in lymphomas. This is a small benefit that it showed, but it changed the survival for a number of people with some kinds of lymphoma, particularly diffuse large B-cell lymphoma. But, for example, Burkitt's lymphoma used to be a disease, a very fast, very angry disease, kills people in weeks. And if you had the old chemotherapy treatment, you cured about 30% of patients if you were lucky. Add Rituxan, you cure 80 to 90%. From one of our worst lymphomas, it became one of our best. So this is early immunotherapy, and Dr. Siegel already talked to you a little bit about trastuzumab, which is another therapy. It's targeted against HER2/neu, which is a growth factor for breast cancer cells. It turns on and it also actually turns on some other cancers like gastric cancer as well. HER2/neu is amplified. It's increased and overproduced in some breast cancers, about 20% of all breast cancers. It makes them into nasty actors. But you can make an antibody against that HER2/neu. We call it Herceptin or trastuzumab. And I was there in 2004, I remember it vividly. They presented the data. These are women who had breast cancer, had it removed, and then were treated with trastuzumab if they were HER2/neu positive, if this thing was over-amplified. I'm not sure I got an arrow here.
There's a pointer. There's on top. There's a.
I got it. No.
Let's see. Does this button here? I don't see it there.
Okay. Well, I'm not getting a pointer, so I'll be the pointer. Anyway, I'm sitting there in the audience as they present this data on this very nasty cancer. It's a breast cancer with high growth rate because it's being pushed by the HER2 protein to make a lot of it, and it's got a mechanism that turns it on. So I'm sitting in this audience of 10,000 oncologists in 2004, and they present these data. These are the patients who did get trastuzumab, and over 30% of them were already dead at a very short period of time, or already had relapsed in a very short period of time, after Herceptin, this antibody against this HER2/neu, and the survival rate and the delay to survival was just amazing. We never saw things like this. It's 20% difference in the number of women who walked away from HER2/neu positive breast cancer. Yes?
I'm sorry, is that administered as part of the chemo, or is it separately administered?
It's usually, almost all those patients are getting chemotherapy and Herceptin. They're getting both. And now there are a number of different Herceptins coming out. There's another one coming out fairly soon, which is going to be even better than the one we have now. Targeting this marker was an astounding event. It was like a rock concert. The oncologists were going crazy because you don't see data where you see this kind of dramatic decrease in relapse rates from Herceptin. More recently, very recently, and I just had a lecture on this today, here's another one with an antibody against CD38. It's another one of these proteins on the surface of the cell. This is for myeloma. It's very effective, and we use it a lot. So that's simple. An antibody against the protein, very simple to do. Now things get complicated. First of all, you can make the antibody treatment better. This is TD1. It is Herceptin. Oops, I'm sorry. It's Herceptin here, and it's hooked on down here. The top point is not working.
I don't know why.
There we go. No,
Could have
not
been
getting
so
it.
maybe.
Whatever. Trastuzumab is over here, and it's hooked to a killer molecule. So it goes after the cancer cell, attaches to it, and then unleashes a poison. And that makes that treatment very much better. And there are a number of drugs out now, including one for Hodgkin's disease, that works the same way. A whole newer and more powerful way of using these monoclonal antibodies. And if one isn't enough, they'll give you two antibodies. This is a new technology that's coming online. There's only one example, but there'll be more, where at one point they give you something that attaches to that protein and then has a receptor to get a attacking immune cell to the same site. So the T cell comes in, the immune cell comes in, and is bound to the cell and can kill it. So this is another advance that's relatively recent, and I heard that there were 3 or 4 more of these in the pipeline where we can increase the effectiveness of immune therapy. This is the ultimate one. You read about this in the newspapers and everything else, and I'm not going to go through it because I don't understand it. I have a PhD in biochemistry, and I don't know how the hell they did this. But what they did was they created something that uses an antibody, just like we talked about before, but instead of just having the antibody go in or attach to something cute, they set up something so that they can take the patient's own T cells and load them up. It's like you handed each T cell a rifle, a gun, and the T cell goes and kills the cancer cell. It's called chimeric antigen receptor. They're getting very complicated. I won't even begin to go through this because I don't know how they did this. I was a PhD a long time ago in biochemistry, and I haven't got the clue as to how they could put this together. But they're able to use viruses to infect, to transmit these rifles right into a T cell, and the T cell goes after the cancer and kills it. Does it work? You bet your ass it works. Look at this. It's 93% CR. These are patients with acute leukemia who've been through everything known to man, and they get a 93% response rate to CAR-T. Now, this is great, and it's wonderful, and there's even more data about this in non-Hodgkin's lymphoma. There's now some data coming in multiple myeloma. Problem is, first of all, these are all the blood cancers. We're not talking about breast cancer or lung cancer or other cancers, so it's a limited population of patients, And second of all, I'm not going to do this work because when you give this treatment, you cause a reaction. It's called cytokine release reaction, and the patients wind up in the ICU for a while. They don't die, but they wind up getting sick. There are a couple of side effects. So it's a wonderful new example of the use of this antibody therapy, and this is sort of the ultimate. I'm not sure we'll get anything better than this with the antibody therapy than the CAR cells, but they're in all the newspapers. You'll see the patients with end-stage this or that, and they're cured with CAR cells. It's very hard to keep the patients away from this. They read about it, and that's all they want. Okay, that was very nice. We had all these antibodies. Now it gets complicated. You think it was complicated before? Now it gets complicated. Okay, so it turns out the T cell on the side gets a signal from a tumor cell, which says, you should kill us. We don't belong here. And there are a bunch of signals that go back and forth between the T cell and the tumor cell. And I won't go through the details, but the problem is, after this nice interaction that says to the T cell to go and kill that cancer cell, the T cell turns itself off. You don't want an immune reaction to explode and kill the patient, right? So you want a turn-off mechanism, so they'll get a signal and then they'll turn themselves off with something that's called CTLA-4. We now have something that will block CTLA-4, so that the T cells not only are turned on, but stay turned on. Now they can go and attack the tumor cells wherever they are. And this was just in the patients with melanoma, malignant melanoma, who were treated with one of these anti-CTLA-4 agents. We never had anything for malignant melanoma. There was just no treatment at all for it. And all of a sudden, we're getting patients on that plateau, about 20% of the patients, that don't relapse altogether from malignant melanoma. This work's been going on for a while. I won't go into detail, but I will tell you that Dr. Bryce sent me a 93-year-old man who had malignant melanoma, ugly thing on his back and a couple of spots all over the place. And we gave him one of these treatments, and he's going into a complete remission. 2 treatments in. I mean, it's an astounding thing to watch, to see this kind of effort paying off so well for these patients. Not only do we have, now I'm not going to get into great detail on this, but the other thing that turns off the T cells is they get to the cancer cell, and there's something called PD-L1 on the cancer cell, these things, and it tells the T cell, turn off, go away, don't bother me. If you can turn off that interaction, the T cell can kill the tumor cell. And in some cancers, we can. So now you got 2 agents, one at the beginning, which allows the T cells to expand and kill whatever they can kill, and the other at the end, which takes the protective mechanism of the cancer cell away. You got 2 guns that you can use, both at the same time in many cases. And this is an example in melanoma. The top curve is the 2 together, the middle curve is just one of the agents, and the third one is a control. So, I'm sorry, it's a different, one is each agent done differently, nivo and then ipilimumab, 2 different agents. So the combination works better than the other 2, than the 2 separately, and you kill melanoma. Look at the numbers here. I mean, we never had anything like this, and you're looking at a 30 or 40% potential cure rate in malignant melanoma, which I never had anything for. These patients all came in, I'd wave some chemotherapy at them, which almost never worked, and they die. And a 93-year-old, I wasn't going to wave chemotherapy at him, and yet he got one of these drugs, and is much, much better. So it's really spectacular. What was that, Mel?
His brain's intact.
Yeah. Well, he's a good 93-year-old. He's fine. I mean, otherwise he just had a touch of a terrible disease that would have killed him within the next few months, but not anymore. God knows how long he'll go, but it's going to be a while. I'm not going to go through all of this, but this is the other one, the one that blocks the T cell from attacking the tumor, because the tumor has a cover on it. Some of these cancers have response rates that are astounding, like for Hodgkin's lymphoma, which they've run out of everything. They come to get this immune therapy, almost 90% of them respond. It's a whole different world. And these are the ones that are most responsive, but it works in many other cancers as well. This is in head and neck cancers. It works there. I'm not going to spend time there. So that the immune therapy system is working in a lot of different cancers, now even in lung cancer combined with chemotherapy. It doesn't work in breast cancer very well, except in a very small subpopulation. It doesn't work in many of the other cancers, but in small populations. For example, in colon cancer, if you have a certain kind of genetic background, it'll work for you. So it's an amazing drug. I have 2 patients with lung cancer, stage 4 lung cancer all over the place, on one of these drugs. One is 3 years, just celebrated his 3-year anniversary on this drug, and the other one is about a little over 2 years in, and they're both in complete remissions. So I said to them, maybe you should stop. And they said, well, are you crazy? I'm alive 3 years in. I should definitely not stop. There's data that they should, but they won't stop. I said to the 2.5-year on guy that you should stop. He said, stop the one who's 3 years in first, and then maybe I'll stop. It's astounding to see this. Just astounding for a poor, simple guy like me. I've never seen anything like it. Okay, the other part of what we are now doing is much more what we call targeted therapy is the other big name that's going around in the oncology world. That started way back about 18 years ago. How do I know it's 18 years? Because I have a patient who's on the original trials for this drug with chronic myelogenous leukemia. He's alive 18 years later, disease that used to kill people in 2 to 3 years. So it's 4 or 5, it's not a very common disease. And they figured out that there was an abnormality in the chromosomes. They called it the Philadelphia chromosome. They figured out what the rearrangement was, and they made a compound that specifically targeted this rearrangement. So it doesn't attack the rest of the body, it just attacks this gene that's been rearranged. And the results are Gleevec, which blocks this pathway, this rearranged gene and how it works. It gets into the ATP pocket and blocks it so that the ATP doesn't work and the whole thing stops working. And it doesn't show, but I have patients alive, this one 18 years, but I have maybe 10, 12 CMLs in my practice, chronic myelogenous, and nobody's died from this disease except one patient who refused to take her pills. But everybody else is doing fine. Years and years and years. There are now 5 different agents that we can use. If they get resistant to one, we can give them another one. So it's an astounding development in molecular treatments, and this is the first one we had. I mentioned before this one, hereditary breast and ovarian cancer, BRCA1 and BRCA2, which is notoriously present in Ashkenazi Jewish women. If a Jewish woman presents with breast cancer, they automatically get tested for this gene, an Ashkenazi Jewish woman, not Sephardic. And they are suppressor genes, so they prevent DNA repair. Now, if you get one dose, it's okay because you got the other chromosome working. But if you're born with one deficient chromosome, sooner or later the other chromosome gets deficient in a very high number of patients. Then you can't repair DNA damage, and you wind up with a very high incidence, 70 or 80, 90% of women who will develop breast cancer if you don't do something about it. And we do a lot about it these days, and they will develop ovarian cancer, 44% for BRCA1 and 27% for BRCA2, all by gene analysis. This is all relatively within the last 10 years that this has all been coming. So things are getting more and more complicated as we figure out these mutations. It used to be simple to treat lung cancer. There was small cell lung cancer, there was squamous cell lung cancer, and there was adenocarcinoma of the lung. 3 different kinds of lung cancers. No problem. You didn't treat any of them very well, but at least there were only 3 that you had to think about. This slide, and it doesn't show very well, has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, something like 12 subgroups of adenocarcinomas. So the lung is no longer 3, it's now 12 or 15 different kinds of adenocarcinomas. We can analyze and routinely analyze the genes to see which one of these has changed, which one of these is mutated and caused the cancer. And we have specific agents for a number of these. We have a large Asian population. They have a ton of these EGFR mutations. They have rearrangements in EGFR that causes their lung cancer. We have a blocker for that EGFR mutation. And they live for 2, 3 years. The Asians, for some reason, live longer. They go 4, 5, 6 years with metastatic widespread lung cancer with a pill. It's a pill called Tarceva, and it takes care of, and there are now 3 of them available, so there's mutations that we can identify, very easily identify, and target the treatment. This is Tarceva, which is like it's a different HER2/neu. Yeah,
What is EGFR?
I'm sorry?
What is
Epidermal growth factor receptor.
And
It's part of we have them in a lot of parts of our bodies. It's part of the normal cell mechanism. A mutation develops that turns it on, so it keeps going and tells the cell, keep multiplying, make a cancer. You can turn it off. Same with ALK. It's another rearrangement that can make a cancer. It's amazing. We now identify these genes. We can get every gene, we can get all these genes analyzed within 2 weeks from any cancer, as long as we have enough cancer material. And then we can pick a target, a treatment that targets that particular mutation. It's astounding what we can do. And this just shows you that what Tarceva does is it blocks the EGFR mutation from working. It's more complicated than that. We actually were very important in some of the EGFR mutations get another mutation, which makes them not respond to drugs like Tarceva.